I'm Crystal. For all those who don't know me, I'm one of the neurologists here through BJC. I'm also the medical director at Progress West, and when I'm not doing other things. So what I'm going to talk about is beyond the guidelines, so complex decisions in modern stroke era. So as you know, we had the ISC, they released some new guidelines, and so it's a really exciting time in the stroke life. And so this will kind of build on some other presentations that we had. And the goal of this is not to be boring, so having some interaction with some cases. So the more you participate, the less I talk, and that's better for everybody. So, oh, here we go. Bueller. Okay, let's try again here. Very good, okay. No disclosures for me. And oh, now we gotta go back. There we go. So the first case is an 81-year-old with confusion and aphasia. So last known well was around 1900, had sudden onset of altered mental status and speech changes when out having dinner with the family. When arrived to the ED at 1943, basically NIH was 6, and so I listed there for loss of conscious questions, being able to answer, follow commands, and then pretty severe aphasia. Although went down for CT imaging, symptoms started resolving around 1950, but not completely resolved. Never had any symptoms like this prior, never had a stroke prior. Medical history is listed here. I don't want to read it to you, but some pertinent positives are hypertension. Also past surgical history up there, family history, does have an allergy to aspirin, but is not on any sort of aspirin or anticoagulant. Does live alone. Son manages finances, but overall has a modified Rankin scale of 1 to 2. And then blood pressure was a little bit elevated at 188. And then when seen, alert and oriented ×2, got the age wrong. Family says those significantly altered from baseline, still having some issues with their speech, and otherwise no motor deficits. So here's the CT head. Does anybody have any thoughts if they want to put on their neurology hat? Do they see anything fun and exciting on this CT? Wrong answers only.
No zebra butts.
No zebra butts, that's right. So overall, normal looking CT head for age, got some microvascular changes, got some small vessel disease, but overall looks good. So if you're in the ED or if you're out on the field taking this call, what should we do with this patient? Having some, aphasia, having some confusion, what are our next steps?
I missed the first part, check the blood sugar.
Blood sugar is, yep, blood sugar was normal around 99 glucose. Temperature was afebrile. So would you want to T&K this person? Would you want to get a CTA? Would you want to just admit them to the hospital under medical management? So remember, symptoms were pretty severe. NIH was 6. Symptoms are starting to resolve, so getting better. So NIH was like 2 once the teleneurologist saw them. What are your guys' thoughts? CTA maybe, okay. So they did end up getting a CTA. Again, this image is a little shifted, so you're seeing more prominently the left side than the right side, so that's not something you should be looking at. The right side is absent on purpose because the image is a little shifted. But do you see anything on the imaging that might strike your fancy? Got some light patches there, yep. So I don't think the laser pointer works, but if you look here, I got my jumping shoes on today. So there is a little bit of stenosis in that proximal M2 region, but it does have good collateral flow, which is probably why symptoms are improving there. So what do you think we should do now? So again, symptoms are getting better, mild NIH. Do you see that we have a proximal M2 there? Would you, still in the window, would you T&K them, call NIR, put them in the hospital? What do you think? Yeah?
Was the NIH, the 2 points on the NIH disabling?
That's a great question. So, family says for him that he's not himself in terms of his cognition and that he is still having a little bit of trouble getting his words out.
I talk a lot, so I would want to be treated for aphasia.
Yeah?
I would do that first, and then I would ask intervention to monitor, because if it is there's an occlusion there, like they're probably not going to do anything for an NIH or two, like go in there and take it out, but just to watch in case they get worse.
Exactly, yeah. Any other thoughts? Okay. So those are all good thoughts. So what actually happened with this patient is that they did not end up giving TNK because they said the NIH was low, symptoms were resolving. Did not end up doing mechanical thrombectomy again because the NIH was low in the risk versus benefit, especially when we're looking at a medium vessel occlusion. So they ended up admitting the patient, did get the MRI. I don't know how well you can see it, but it does have some little punctate infarcts there. Patient ended up discharging, but because he wasn't quite to his baseline, family was worried about his cognition. He ended up going from living independently in his own home to now going into an assisted living. Okay? So the next case that we've got here is a younger person, so a 50-something-year-old female, right-handed, now with weakness, numbness, and some other changes. So again, when she was driving down the road, all of a sudden she just had sudden onset of right-sided weakness, right-sided numbness. She was apparently talking on the phone, had some trouble getting her words out. So again, the initial NIH was pretty high. But again, symptoms by the time she got to the ED, went through the scanner, all of her symptoms had resolved. And so in the interest of time, I won't read all of the other kind of pertinent medical history for you guys. Blood pressure was a little bit elevated. Glucose, as you can see here, was elevated. So they ended up getting a CT scan. CT was unremarkable there. So what are you guys thinking in terms of next steps here? Any thoughts? Well, these people like to get CT scans, so we went ahead and got a CT of the patient. Didn't end up getting any TNK because, again, symptoms were resolved. And here, again, you have to take my word for it and the radiologist's word for it, that you can see on the left side there's some distal occlusion in the M2, but again, good collateral. So again, another reason probably why her symptoms got better. So knowing she had symptoms, they've now completely resolved. She does have this distal occlusion, does have good collaterals. What would you guys want to do with this patient? Medically treat her, okay. And so that's what ended up happening with her again. Because her symptoms were resolved, she's not a TNK candidate. She's not a mechanical thrombectomy candidate, even if she did have symptoms, because it's a distal occlusion. There's not a whole lot we can do about that. Unfortunately, after she got admitted, she had worsening of her weakness, and so a rapid response was called. CT did not show any sort of bleeding or infarct at that particular time. Did end up getting an MRI, which did show an infarct. And when she got discharged, because she's an artist, a freelance artist, she does a lot of teaching, art school, she felt like her weakness, even though there wasn't significant weakness on her exam, she felt like she was affected to where she couldn't do her job in the same kind of way. And then last case we'll talk about is a 65-year-old with altered mental status and also aphasia. And so this one went to bed. Husband, she was normal the night prior. Next day he got up and he went out and did his husbandly things, came back home in the afternoon and she was still sleeping. And so when he woke her up, that's when he found out that she had pretty dense weakness and was altered and not really doing a whole lot. So ended up calling EMS, arrived to the ED. She still had fairly dense symptoms when she got there, but now we're in a pretty extended time frame, okay? Prior to all this, she was working part-time at the law office. She had an MRS of 0 at that point, okay? Blood pressure, again, is a little elevated, glucose 103, okay? CT, nothing fun and exciting on that CT exam. Any thoughts what we should do for this patient? Or what can we do for this patient? Anything? More imaging, exactly. So they did get the CTA, and unfortunately nothing fun and exciting was found on her CTA. There was no large vessel occlusion at that point in time. And so next steps, there's really not a whole lot we can do. She's out of the window. She doesn't have a large vessel, so we ended up admitting her. We didn't get an MRI because she has pacemaker. We can't do that at our facility out here, but she was out of the window, so no TNK, no LVO. She had the pacemaker, and so then ended up having to go to rehab because she still had some pretty profound deficits at that, okay? And so what I'm using all of these cases to consider is, now that we've got these newer guidelines where we're starting to talk about extending our thrombolytic window, starting to do mechanical thrombectomy on patients with less severe deficits, but imaging that there is a penumbra to go after, could any of these cases been changed, especially because when we look at the outcome of these cases, they actually did affect their overall quality of their life. So that's kind of why I say beyond the guidelines, because what we know is that stroke care is evolving faster than we can keep up with and get a whole consortium of people together and make guidelines to put out there for people like neurologists and ED physicians and EMS and nurses all to follow. And so, also with all the other things that are changing, our AI technology is interpreting images for us in real time. So you don't even necessarily, you need a neurologist, but you don't necessarily need a neurologist in some of these instances to really look closely at some of these images, because they'll pop up and tell you large vessel, evolving stroke, bleed, things like that. So there's a big major shift. Also, everybody talks about time is brain, time is brain, time is brain, and that is true. But now it's not so much time is brain necessarily, but also tissue is brain. So we really need to start looking at what does the tissue look like in these people, even though maybe their time isn't optimal and isn't to our smaller community hospitals, but that would be the goal.